speaker of the session before our panel discussion is Ed Felix, our fearless leader here, and I'm kind of surprised that you're arguing this side of the debate here, Ed, because I remember in the early days you were so interested in the triangle of doom and the triangle of pain, and I believe there was the hyperbole or the hyperbole of Fresno, wasn't that what it was, or the
Something
you
like
had some
that.
name.
Fresno's a dangerous place to be, especially on the west side. But, you know, Dr. Reggie is really making me sweat over this thing. So I'm going to undo my collar a little bit and get down and dirty, since I've known Maurice a long time. And we'll get to the truth and bring it up to the 21st century in 2011 and get him on the right page, even though I'm old, like someone showed. In fact, Guy and I didn't have those cell phones back then when we started this. We didn't have cell phones, but we'll get started. All right, so the question is just the same as he said, to fix or not to fix. Really, I don't think that's the question. The real question is, can fixation prevent recurrence? And that's what I'm going to try and answer. Well, why do laparoscopic inguinal hernia repairs fail? And I'm going to go over this quickly because it's been covered a lot in his slide, but mainly it's poor technique, lack of education, lack of experience. We've seen that before in every talk up here. You have to be experienced. In the paper he referred to with the 10,000 cases, not all mine, there were a number of surgeons in there contributing in the early days, in the early 90s. Really, it was inadequate dissection, a slit in the mesh, too small a mesh, shrinkage, and the last one was lack of fixation. All right. If it isn't fixed to the wall, what can happen to the mesh? So if we do it Maurice's way and we don't fix it, what can happen? Well, there can be total movement of the mesh. It can slide around because even though he spits in there to get it to stick, it doesn't always stick right away. It can roll up. There can be lateral roll up, medial roll up, and what I call total roll up, sort of like my blinds at home in the morning. Or it just caves into the direct hernia. So those are all the ways it can fail. Mesh displacement. Just a couple examples. This is a large direct recurrence where the mesh is totally rolled up on the medial side only. The indirect side is still there. There was no hernia. And the other one shows what looks like a big direct hernia. It's really a recurrence on the indirect side, but it's so big it looks like a direct hernia. So the mesh can totally disappear. Sometimes you'll look in there and it's just gone. Where'd it go? You don't know. You know, especially if you did the case, you know you put it in there. If somebody else did the case, you go, you swear, no, they didn't put any mesh in. But there is mesh in both of these recurrences. So it migrated up, down, sideways, all around. Well, can mesh displacement be prevented? That is the question. Maurice doesn't seem to think so. Well, number one way you can prevent it, if you're going to do the non-staple technique or non-fixed technique, is have a good anesthesiologist who doesn't buck the patient immediately when they wake up, because if you do an extraperitoneal TEP and the mesh isn't fixed and the patient starts bucking, that's when you get your recurrence. So the first thing is get your anesthesiologist off the phone, make him do his job, and maybe they won't be bucking. Next, don't put a slit because slits cause recurrence. Our early studies showed that. Barry McKernan, all of his recurrences were through the slit. You got to use a large mesh. We've said that. And the surgeon's job, well, there's two things we can do as a surgeon besides technique. One is flatten the mesh out so there's no wrinkles, because if you have wrinkles, no matter whether you do it anchored or not anchored, that recurrence is going to occur, or pain. And finally, you can fix it to the wall. What happens if you fix it to the wall? What can you prevent? Well, and how can you fix it to the wall? Well, Maurice wants to make us think all we can use is staples or tacks. Well, nowadays we have all kinds of options, and I'll try to confuse you more by showing you all of those options. We can staple it, we can tack it, we can glue it, and we can even use Velcro, or a Velcro mesh, I call it. If you go back in history, when we first started, we started with 10-millimeter staplers. They were these big, clunky, straight things. Then we moved on to articulating staplers, which only a couple people in the country still use, didn't catch on too much. Then we developed a spiral tacker, and now we have absorbable spiral tacks, permanent spiral tacks, and tacks of all kinds that every company in the world that's here in this audience has presented to us. Many options. Well, does conventional fixation eliminate the problem? And Dr. Reggie said no. Well, in some ways, he's partially right, so I'll give him some credit. Partial credit. Partial. Shh, my turn. Partial. You can't, if you have to put your anchors, if you're going to put tacks, staples, anything, metal, plastic, you've got to put them above the iliopubic tract. So, yes, it eliminates displacement above, it eliminates roll down, but it will not prevent in any way roll up or cave in. Okay? But I agree with Dr. Reggie. If you put tacks, you got to be very careful because in 15% of patients, their anatomy isn't the way it's supposed to be. That was shown by a German group many years ago in a cadaver study. 15% of people, the nerves that are supposed to be below the iliopubic tract are truly above the iliopubic tract. And if they are, and you put tacks there, you'll injure them. I agree with Dr. Oreghi. So what should you do? This just shows you cannot, this is my experience in 5-year follow-up, 1,925 patients where we use tacks in all of our patients. This was from 1991 until approximately 2000. And then we went back and looked at the patients. We had a very low recurrence rate. I used to say, in fact, if they didn't recur the first year, they'd never recur. I'm here to stand and be honest and tell you that is not true anymore. I now have some late recurrences, one as late as 10 years afterwards. So lap hernias do recur after the first year. But complications from the attacks, we really didn't have any patients in that series with chronic pain. Some with early pain, no chronic pain, no patients re-explored. So I don't think the problem is big as Dr. Oreghi would have you think. You can put tacks safely. In fact, there's another surgeon, Dr. Chaubey, 1,193 TEPs, 0.5% recurrence. It's not the VA study, obviously, but it's 0.5% recurrence. 6 recurrences, 3 missed and 1 medial. He used tacks, very low recurrence rate. Well, what can you do if you don't like tacks? If you're Dr. Oreghi and you say, I don't like tacks, well, what else can you do? You can use glue. What will glue do? Glue will eliminate displacement totally because you can put it above the iliopubic tract, you can put it below the iliopubic tract, so you don't have roll up, you don't have roll down, you don't have movement. So glue seems like a really good idea. And you eliminate nerve injury. There are several studies, and I apologize to Dr. Ketkutas in the front row because he's really the father of this. And next time I'm putting your name up there because it belongs there. Several studies done with glue, both in animals and humans. Dr. Veller's got one of the best. 600 hernias, basically no recurrence with glue. So glue works. And in most of these studies, what you found was that glue decreased pain, but in some it increased the incidence of seroma. So does glue work? Yes, it works. Is it better than tacks? May have less pain, but there's some question of its increasing seromas. Is it better than no fixation? I'm here to say it's only theoretical. There are no randomized studies that I am aware of. Maybe Guy can let me know, but there are no randomized studies between glue versus no fixation. How'd you like that, Maurice? I'm on your side again, huh? All right. There's a newer way even than glue. It's called Velcro. Not quite, but I don't want to name any companies. Velcro mesh is a mesh that when you put it in, it sticks against the wall. There's a nice study done by Kingsnorth from the UK with open hernia repairs. In that series, they presented it in short-term data, but they just recently presented it to the American Hernia Society. Less pain at 1 to 3 months, no recurrences. Seems to work as well as suturing for anterior hernia repairs. And Dr. Jacobs, who just lectured today, was nice enough to give me one of his videos. He has experience with it. I have no experience with this mesh, but it works in his hands, no recurrences. Whoops, it was supposed to be a video, it didn't play, but it basically shows you putting in the mesh. The only downside, I think, of the mesh is if you put it in, you have to be very careful because once it's Velcroed, in every video I've looked at, it's Velcroed. So in other words, unlike my mesh, or my fellows' meshes when they put them in, if you put them in the wrong place, you can move it. You better put the Velcro mesh in the right place the first time. And Dr. Jacobs can speak to that because he's got the experience. Does self-fixing mesh work? Yes, I think it works, but we, again, have very limited data. We don't have any long-term studies, but I present it because it's out there. Is it better than tacks? Yes, it may cause less pain. Is it better than no fixation? Here we go again, Dr. Oreghi. I don't know. We have to do randomized studies, but it works. Should you use fixation routinely? Only if you can do it safely. If you're going to do like that patient we saw, and I actually was sent the same patient that Dr. Oreghi saw. He traveled to every expert except for Guy Beller, he missed that name, in the United States for all those tacks. And I actually sent him to Wisconsin to have his mesh and tacks removed. if you can put them in safely, tacks appear to be extremely safe. The incidence of pain after tacks is very, very low. Proper placement is important. Should you use absorbable tacks? There is no scientific evidence that I am aware of that absorbable tacks work any better than anything else, cause any less pain, but they're out there. If it makes you comfortable, put them in absorbable tack. That's probably going to be there a year. That's fine, but I can't find any evidence compared to anything else that it's better, worse, or indifferent. Glue, we have that evidence. It works. It's new, but there are some nice studies to support it if you want to use it, and the same with the self-fixing mesh. What is my personal plan in 2011? For the last essentially 9-10 years, what I've done is selective placement. So I'm giving a little bit in to Dr. Arregui. I do selective placement of tacks. I use a technique similar to Dr. Arregui's in most cases, but feel there are many cases where tacks should be used because you'll have a recurrence, or some fixation should be used. I think we would have prevented the recurrence on Dr. Arregui's friend if that patient had that mesh fixed and been bigger. I think there are skinny patients who you try to put the mesh in, and anybody that's done this will agree. You put it in, and the vessels are coming so straight back at you, it just doesn't lay down. You've got to get it a way to lay down. Glue or tack, something is a better fixation. Probably in those patients, actually glue, because you can't fix it below the iliopubic tract. Sager is taken the same way that I have done for the last 10 years, and basically in 822 patients has a 0.7% recurrence rate using a selective technique for fixation. So I'm kind of going waffling on you, like some of our other speakers. No recurrence in his series, and no neuropathic pain with the mesh, with selective. So, what am I telling you today? Even though this meeting isn't being held again in Las Vegas like the last stages a few years ago, it's dealer's choice. You can do what you feel are comfortable with, but any one of these techniques right now are acceptable. What I'd like to do now is get the rest of the panel up here.